Well, thank you for that introduction. I would like to confess that I'm a vascular surgeon, but half my work is soft tissue. And I was just lamenting the Fabrizio. I never get the chance to come for podiatry meetings, and I'm just looking at the topics that I want to come, but I'm going to try to skip a few on the other side and hop over here to get educated myself. But thank you very much for that introduction. I work in Singapore, and we have a population, a large number of patients with diabetes. 90% of the patients we see are diabetes, 20% on dialysis. And the problem in critical limb ischemia is caused by calcium, and that leads to a transmission failure and a distribution failure, as put forward elegantly by Ferraresi and friends. Transmission failure is anything from the iliacs all the way to the dorsalis pedis. So distribution failure is really distal. We call it small artery disease, or aptly SAD disease, and that leads to a desert foot. So we do have angiographic foot scores available on evidence. I'll run through a couple of these. This was a score by Dr. Boulos and friends, evaluated the dorsalis pedis, medial plantar and lateral plantar arteries, and each was scored according to the degree of stenosis that they saw in the angiogram. And they found that in patients with diabetes, this angiographic foot score was predictive of a likelihood of a graft failure, bypass graft failure, and subsequently limb salvage in the infrapopliteal space. Dr. Karawada, an interventional cardiologist, was described several styles of pedal arch anatomy. As you can see, type 1 involves the presence of both the dorsalis pedis and lateral plantar. Type 2, absence of the posterior system, and type 2B, absence of the anterior system. And type 3, or no pedal arch vessel, is similar to what we would say as a no option for distal bypass or an endovascular intervention. It did find that if you look at the hard endpoints, and I always say this to my trainees, let's not talk about AFS and limb salvage. All these are all subjective but essential. But if you look at the hard endpoints of complete wound healing, you can tell that in patients with severe distal vessel disease or SAD disease, an example of a type 3 pedal arch anatomy, you can see that the wound healing is significantly lower compared to the other two. If you look at the data from this same group, if you look at the wound healing in patients with a typical SAD disease, you find that the wound healing or complete wound healing is pretty dismal. It's only 30% at 6 months, and if it doesn't move by 6 months, it's not going to move by 12 months. It's still running around 30%. And these patients end up with what we call the salami effect by Ferraresi, which is you start taking one toe, two toes, and sooner or later you're on a transmat and a BKA. Some other foot scores were available. The paramalleolar arterial Bollinger score, a little bit of a mouthful, but PBS for short, provides an idea of not just distal vessel disease, but also distal anterior tibial, posterior tibial, and peroneal vessels. And with that, the score was associated with a worse outcome after infrapopliteal bypass surgery in patients with diabetes or end-stage renal disease. More recently, Dr. Ferraresi, who did a lot of work on this, had a look at almost 2,000 patients, 2,000 limbs in 1,600 patients, and he looked at the distribution of peripheral artery disease and ran an odds ratio risk factor for critical limb ischemia. He found that if you had below the ankle an arch disease, you had odds of 13, odds ratio of 13 was strongly independently associated with critical limb ischemia. Similarly, if you had more BTK vessels that were diseased, you were at higher risk of critical limb ischemia. So angiographic scores were also useful. The problem with angiographic scores, as you can see, it's pretty subjective between no small artery disease, moderate small artery disease, and severe small artery disease can vary from individual to individual. So he sought to take a look, and is there a better way that we can identify these patients without the subjective angiogram? And he decided to do a calcium score of sorts for the heart. This is what we call the MAC score, or medial artery calcification. And this is a pretty simple score. You would on AP and lateral projection of the foot, you take a look at the dorsalis pedis, and if that is more than 2 centimeters of visible calcium, that would score as 1. On the lateral plantar artery, similarly, more than 2 centimeters score at 1. And then on the AP radiograph, the metatarsal artery or digital arteries hitting to the toes more than 1 centimeter would be 1, and similarly further up, and the other toes as well. So you could score these into a low MAC or no MAC, moderate MAC, and severe based on 0 to 1, 2 to 3, or 4 to 5 classification. What he did was, in the same group of patients, he looked at the SAT score, the angiographic score, and found that they correlated very well in terms of the no MAC, moderate MAC, and severe MAC. You can see the sensitivity and specificity was pretty good. So you can take a plain X-ray and you can predict the amount of small artery disease on angiogram just by looking at the X-ray. Now, why is it important to know just by looking at the X-ray? Because the MAC score, or the medial artery calcification, affects cardiovascular survival. This is an analysis of 10 years of study patients diagnosed with type 2 diabetes, and he found that if you had a higher MAC score, it was a recipe for death. MAC score also affects the limb outcomes. In a meta-analysis of 15 studies of 6,500 patients, a higher MAC score was significantly associated with all amputation as well as major amputation. Looking at the X-ray of the foot, you can also tell if you are going to end up with a problem of wound healing. In his center, which has a good collaboration between him, who is a cardiologist, as well as the podiatrist, he found that even in the best hands in his center, at 12 months, which is a very reasonable time frame for complete wound healing, very generous amount of time for wound healing, complete wound healing in patients with moderate to severe MAC was only less than 30%, very similar to the Japanese series that we saw with also complete wound healing at 30%. So next time you do an angiogram like that, or next time you want to do an angio, take a single shot before you shoot the contrast, even get access to the leg. You know you're going to be in for trouble. Call your wife or your husband and say that you're not going to be home for dinner, you're going to be fighting this for a while, and have realistic expectations on what you are going to do for these patients in both, from a revascularization point of view, as well as a soft tissue point of view. So in summary, foot scores like the MAC score help to predict angiographic success or strategies, prognosticate cardiovascular survival, anticipate limb outcomes like complete wound healing, and can guide clinical decision making in terms of how aggressive you want to do and how many toes you want to save. And this can help to compare outcomes across different studies in patient cohorts. Thank you very much for your attention.